Hello and welcome to All Coronary Physiology Cardio Webinar Series. Please subscribe to our channel to receive most recent webinars related to coronary physiology, assessment, and innovation. Thank you for watching.
Hello everyone, my name is Shad Reyes and welcome to All in Coronary Physiology webinar series. This time we are coming to you from Middle East. We are really privileged to have an esteemed panelists and speakers to talk about the role of physiology in a cath lab and maximizing tool when the options are few. We know that the COVID has been really coming back and the pandemic restarting again. So the main purpose of the series now is to focus on how to give the patient the best results in a cath lab, minimizing coming back to the cath lab for more revascularization and also do complete revasc in as few sessions as possible. We are privileged to have faculty coming from Egypt. So the first speaker is Dr. Ahmed Samir. He is a cardiology lecturer at Cairo University, associate consultant at the Sawwah Heart Center in Egypt, and also Dr. Haytham Al-Qadi, consultant cardiology at Banaha Teaching Hospital, a deputy head of cardiology department Wadi Nil Hospital, and Dr. Ahmed Sawwah, consultant interventional cardiologist at National Health Institute, and he's the head of the cath lab at Mabarra Cardiac Center. Thank you all for being here. Thanks for the speaker for arranging this and putting your slides together. For the participants, please use the Q&A box throughout the program to post questions and we entertain them with the speakers. Dr. Samir, please, we can see your slides. Please go ahead.
Thank you, Dr. Shadi. It is my honor and privilege to be joining you in this nice day. Now I will present a case where we should have maximize the tools when the options are few. My patient was a 76 years old male. He was an ex-smoker, hypertensive with type 2 diabetes mellitus. He had peripheral arterial disease with previous bilateral lower limb percutaneous transluminal angiography. However, he had stenosis. He was complaining of crescendo pattern angina over the past few months and class 3 currently. He had a coronary angiography that was after a non-STEMI that occurred 1 month earlier, and the coronary angiography revealed multivessel disease. He initially was advised for CABG. However, there was some resistance from the surgeons knowing his background, the clinical background of the patient. The EF was 45%, the ventricle was mildly dilated, he has hypokinesis in the whole inferior and infralateral plus the apical segments. The previous coronary angiography was performed through the right radial, and now it is impalpable, and thus my patient had only a vascular access through his left arm to perform any needed revascularization. Through the left radial, we angioed the right coronary. It shows total occlusion. However, the previous angiography was around 10 to 14 days ago, and there was an antegrade flow. So we were confident that this is not a chronic total occlusion. The left system is giving retrograde filling into a super dominant right coronary. And now we have the left system showing that a ramus or a high lateral with a proximal very long lesion with no appropriate landing zone except for the left main, and we have an eccentric plaque in the mid LAD just prior to the origin of the large diagonal, the first diagonal. This is the ramus and how it looks, and the retrograde filling into the right coronary system. And so, sitting with the local surgeons in my institute after this new angiography, now we have an eccentric proximal LAD lesion acknowledging that the LAD is the main donor for the right side, the right coronary and the PDAPL branches. We have a long proximal lesion in a sizable high lateral, despite there is no very appropriate proximal landing zone for that lesion. We have a total occlusion of the RCA with the retrograde filling from the left system. The challenge in revascularization options that for considering my patient as a cabbage patient, he has uncontrolled diabetes, he has extensive peripheral arterial disease, and actually the surgeons had very big concerns, not for his targets, but about the rehabilitation postoperatively and the healing of his leg and mediastinal wounds. We thought of a DPR FFR for the left system lesions upfront. However, we were under a strong impression and concern that an FFR DPR for the LAD, acknowledging that it is giving a whole LAD and right coronary territory, will overestimate the degree of severity, and we might be doing something that is not very justified, validated. And for a multi-vessel PCI, we have definitely the limitations with the single left vascular axis. And thus, the heart team discussion was not the sweetest discussion. However, we moved to a syntax calculation. We calculated the syntax score for all the 3 lesions, and the total for syntax 1 score was 29. However, incorporating the clinical profile and background of the patients, we found that the 4-year mortality for PCI is 40%, but it was 75.3% for cabbage. And thus, we had to move on for PCI. Again, and as expected, we started with the right coronary. This was a sign black wire, and cautiously, we advanced the sign black. Unfortunately, we hit into the distality of the RCA. We dreamed of having retrograde filling injections. However, this was not available for the limitation of the axis. We dilated cautiously with a 1.5, then 220 balloons. Unfortunately, we were in the distal through. Now we try to advance a Promise Premier 338 millimeters, but it could not be advanced distal enough to be confident that we are covering the long lesion in the mid RCA. And we were a bit surprised that by advancing the Promise Premier, the distal flow into the RCA branches got significantly impaired. At this stage, and because we were wiring blindly, we opted for removing the stent and wiring the second branch, the side branch with a pilot 50 wire to preserve both. It would help for preserving the side branch and as a body wire as well. Now, the Promise Premier was beautifully advanced just prior to the polygon of confluence of the 2 distal branches of the PDAPL. And it was deployed. After the deployment, we just withdrew the balloon slightly to help for sizing and give injections. However, the surprise is that the distality, the flow got significantly impaired, and we were having large concerns to have stented subintimally. At this stage,
can I ask you?
Yes, sure.
Did you perform any IVUS imaging for advancing the stent to make sure luminal?
No, as a matter of fact, we did not, because we did not have any concerns when advancing the sign black, or even when advancing the second branch, that there were any difficulties. Particularly, and as I have mentioned, that this occlusion might have been occurring through the few days earlier than our intervention, because like 10 days earlier, there was good anti-grade filling into the distality, albeit the significant lesions but there was antegrade feeding into the distality of the right coronary. Actually, we did not perform intracoronary imaging prior to stent advancement.
Thank you.
Sure. But now it was not luxury to choose to do it or not. We advanced an IVUS probe to ensure where we are and where our stents have been deployed. To cut a long story short, this was coming from the distal PDA, and this is the transition between the distal to the stent lumen and the stent. The stent is in the true lumen.
It's a true lumen, yeah.
Yes. Back to the intimal plaque that it is inside the proximal RCA, and this is the proximal lesion where we opt for a new stent. So the IVUS imaging was reassuring. This is the other wire at 12 o'clock of the side branch. The IVUS
with this collateral coming left, right, even with that abrupt flow and an RCA, I think the patient was stable because you have a very robust collaterals coming from the left.
Yes, exactly. The very good retrograde filling of the right coronary branches from the left system gave us the luxury to have a stable patient inside. At this stage, we acknowledge that now we have pharmacologic or functional no reflow, and we opted to implant the next stent assigned 3.548 proximally, and we take it from there. We implanted the designs covering the ostium, and with the same balloon, we opted for post-dilation of the overlap segment. And for the good that after deployment of the designs, the flow got markedly better, with more and more pharmacologic management with nitroglycerin and isopten, the distal flow returned back to normal. Now it was at the time to post-dilate our stent with a 3.5 non-compliant balloon, inflating the ostium. And this is our final results. And having an IVUS on site, we performed a final IVUS check. This is the distality of the BDA. It grew a lot after stenting. This is the transition, the distal edge of the stent. The minimal stent area was very appropriate, and we ensured that we have covered back to the ostium.
It's very well opposed and expanded, and I think you did a good job post-dilating that lesion. And the transition, there is no edge dissection, and you left no lesion beyond it. And I think the PDA was small. I don't think worth pursuing it, but you have TIMI-3 flows, perfect result.
Yes, thank you. Now, after opening the antegrade flow into the right coronary, now we have that the LAD is fulfilling the demands of the LAD territory. And thus we advanced the OptoSens system, equalized, and for the good that the DPR was 0.92, FFR was 0.9 in the LAD, and 0.96, 0.93 into the ramus or the highlighter.
Wow, that's surprising.
Denoting, yes, surprisingly, denoting a functionally non-significant lesions. And this was a check angio after advancing the wires.
Well, this is like a big save. As you said, decision-making was important. This patient could have gone for surgery with a complicated course post-op. But I would like to applaud you for doing the quote-unquote semi-CTO RCA first before doing physiology, because we know that donor vessel physiology for a patient who has CTO on the contralateral side has been physiologically been abnormal, falsely abnormal. But by fixing the CTO first and then studying the physiology of the donor vessel, you'll have more accurate result. Excellent work.
This is exactly, and I think this is the message that we have to conduct to our colleagues, that coronary physiology is assessing the demand-supply mismatch. And if the demand is abnormally high, you will have a falsely significant lesions. And thus my take-home message was that you have to maximize the tools when facing a challenging scenarios with very few and limited options. The coronary physiology and physiology-guided revascularization is becoming the standard practice. Functional guidance can spare unindicated complexities, yet this has to be done appropriately. And thank you.
Thank you so much. This is excellent result. For the audience there is a poll has been posted where we're getting the second speaker ready. What clinical evidence do you refer to decide whether to use physiology, FFR, DFR, and NSTEMI? Is it the FAME trial, famous NSTEMI, or other? Please post in your feedback in the chat box. But this is really an excellent illustration. I would like to thank you for preparing this presentation, and very interesting case. Has multiple utilization of physiology, imaging, and also wiring techniques. How you protected that big RV marginal before the stenting. One question comes up, it's a little bit technical. People are afraid of jailing that wire, the wire that you had in the RV marginal. So did you pull it out before stenting, or you pull it out before post-dilation?
Actually, and this what we have learned from our professors. I usually advance the second stent first while the wire in place. And after appropriate positioning, making use of that, this gel wire is offering me a very good support, I pull it out before deployment. This is usually the practice, not to jail a wire for a very, very long segment in an already calcified vessel. This is a 38 and a 48 stents. And actually, because of the overlap segment, the wire will be jailed between two layers of metal. In some occasions, we can break that rule when the support is deemed necessary and mandatory. And I have anticipations of facing challenges when advancing future devices like the NC balloons or so. But in the majority of cases, we go exactly like what we had done in this case. I advance the stent, the second stent while the wire in place, then I remove it before deployment.
Excellent work. Yeah, excellent work. Is Dr. Sawwah ready for his presentation?
Okay, I'm just facing some technical issue. I'm trying to solve it now.
No problem. Yeah, if you can share your screen when you're ready. So Dr. Sawwah, to remind the audience, he's a consultant interventional cardiologist at the National Health Institute, and he's the head of the cath lab at Mabarra Cardiac Center. We're supposed to have a third speaker. We are just waiting to confirmation. Maybe there'll be cancellations, or maybe the program will have only 2 presenters throughout the program. So just to report the result of the poll, what clinical evidence do you refer to decide whether to use physiology? Majority of the audience went with FAME trial. Again, for the audience who joined us late, I would like to thank OpSens Medical for sponsoring the program. We come up every month with physiology cases and different utilization of OpSens and OpSens technique and OptoWire in a patient with multivessel coronary disease, patient with NSTEMI, stable ischemic heart disease, and how to be cost-effective in utilizing one wire to complete your revascularization and ischemia assessment. Also, all these webinars are recorded and posted on the OpSens YouTube channel. So if you Google OpSens Medical YouTube channel, you have all these webinars saved. And I think I should take advantage of this archived material there. Phenomenal resources for interventional cardiologists, fellows, and training. So are you able to share the screen, or it's not coming up?
Yes, now I think I'm able to do so.
Yeah, I see your screen now. Yeah. If you want to put in presenter mode.
Sorry for being late, but there was a small technical problem that I managed to solve. First of all, I want to thank Dr. Ahmed Samir for his great presentation and great case.
Thank you, Dr.
For me, I'm presenting 3 cases that, for me, I was trying to deliver a simple message that physiologic assessment of the lesion may help guiding the decision of the interventionist. My first case is diagonal and RCA case, male patient, 67 years old, diabetic peripheral artery disease, complaining of typical chest pain, ejection fraction showing resting wall motion in his lateral and inferior wall. When we did the coronary angiography, as you see here, we found that diagonal showed a small focal lesion. For me, without the DBR rule, I wouldn't stent this lesion, or I send the patient for Salium study or something else. I won't stent the lesion within the procedure. We did an IFR for the case. We found that cut value was 0.59, which is very significant. So we took the decision of stenting this lesion. Also, he had an RCA with which we'll see now. As you see, we give here Stridil. We thought it may be a spasm. We give once and twice boluses of Stridil. As you see, patient here, the spasm is resolved, but the IFR ratios was still there is less than cut value. So we go for decision of stenting and did an IFR post the stenting that showed that it's improved. The case number 2, it has an LAD lesion, female patient, 59 years old, positive family history, chest pain on maximal medical treatment. We did here also IFR for the lesion. Here it's a mid-segment lesion. The rule here for a pullback technique for the IFR for positioning of the stent, we found that it's a diffuse LAD lesion. Here we put a stent, then after this stenting, we assessed the proximal to the stent. We found also that still significant. Another stent was deployed and inflated, then IFR post-stenting showed improvement.
So, Dr. Sawwah, so you did you perform a pullback to find out where is the step? Yeah.
Yes, we did a pullback that showed that the proximal to the stent there was a lesion, and there is still drop in the values. And this is one of the great rules for DPR in this case, because after we did the first stent, maybe we finish the procedure and the patient will still complaining and have chest pain, and we won't find the cause. The last case is interesting. It's an osteal Lcx case, and as you know, osteal circ is one of the most challenging cases that you find. Patient is complaining of chest pain with positive family history. She is 55 years old without risk factors, with echo showing no resting wall motion abnormalities. This case here, we after doing the DPR, we found that she has no significant lesion. DPR showed cut value 0.94. So in this case, we didn't go for stenting, and we managed to do medical treatment. We maximized medical treatment. And as you see, DPR here is not also for stenting, but also for not to stent. This case, I think it's a great challenge, because it will go for a left main circ bifurcational lesions, which will be a very complex procedure for this case. And of course, she will not have any improvement, because as you see, the physiologic assessment shows there is no affection of this lesion. For us, without the DBR, I think by this shape of lesion, maybe we go for stenting guided by the typical chest pain and high complaint and the angle showing this as a tight ostial circ. But DBR actually helped in this case and managed to just do medical treatment.
So this case builds into the FAME-1 trial when physiology has ruled out the need for stenting in 37% of the, meaning we visually and geographically we see something, and if we didn't do any physiology in this case, we could have been attempted to stent it, and maybe, as you said, it's going to be difficult bifurcation, distal kind of ostial circ, but this physiology here helped differ the patient from therapy, which is, I think, was a perfect decision.
Yeah, I see. For the 3 cases, the DBR guided the decision. For the second case, we were in the gray zone, 0.89, and the patient was typically complaining of typical chest pain on maximal medical treatment. And so for this, it's operator dependent. We thought that we need to go. When we put the first stent, we found that there is a lesion that appeared proximal to the stent. So we put a long stent for this patient. And I think he managed to benefit from this PCI intervention.
All right. Right, and I think it's one of the great lessons about physiology post PCI is, as you nicely illustrated, Dr. Sawwah, is when you are connecting and reconnecting, which is this is one of the best feature for OptoWire, is that reliability and of the wire is still constant despite you balloon, you stent, you post dilate. The wire has a great reliability in continuing to provide actual values and data. And that's what helped you in this case. When you performed a pullback, you saw there's a step up. And as you mentioned nicely, is if this patient could have gone off the table because angiographic result is perfect, she will continue to have angina. So there's a nice book published by a Korean group just 2 months ago, going through algorithm for post PCI abnormal physiology or DFR or IFR, whatever physiology you're doing. And the differential always either you have under expanded stent or they are missing a lesion in the proximal or distal to the stent, or you have maybe a dissection that's flow limiting as well. So this is where I think physiology helps when you pull back, and that helps defining the area. And also you can complement this with some imaging if you want to do IVUS or OCT to see exactly what's the problem. So for the audience, also have a second question on the pool. What are the most important pressure guide wire feature for your clinical practice? Performance, I want a wire that can cross lesion easily. Accuracy, I want to be able to perform repeated measurement without drift, as I mentioned earlier. Number 3, choice, I want to be able to use FFR or resting indices. Or the last option, freedom, I want a pressure wire that perform like a workhorse wire to diagnose and treat. I think there's something you have, I mean, we should have an extra option also that says all of the above, because I think this is what everybody wants. Something like cross, reliable, give you reliable readings, and also despite repeated angiography, PCI and balloon angioplasty. Sawwah, is this your slide? You want to continue, or this is?
Yes, it's still mine, but I just put the 3 cases into, and I think that you covered all the data I was going to say. As you said, an easy procedure for the wire that you can disconnect it and use it as a PCI wire, has better control during complex cases. Easy to deliver the stent, then reconnect. We do not need to go outside and assess the pressure again to re-enter the wire through the lesion. I think these are all in advantage for the TPR wire.
Absolutely, and it's very nice, diverse cases. One is showing post PCI, one showing how you differ therapy, and the third one showing how many visits you need to revascularize. Very nicely illustrated for utilization physiology. So I think we are supposed to have a third speaker, but again, unfortunately, maybe due to emergency, he's not able to join. Is Dr. Al-Qaid, I think he's supposed to come. Haytham Al-Qaid. Meanwhile, if the audience there, if you have any questions, please put it in the Q&A box. We can entertain it with the panel. Or if you have any experience with the wire or any physiology questions. Meanwhile, I would like to ask the panel, what is your protocol or your practice for a patient presenting with STEMI or NSTEMI that has a culprit lesion, but there is other lesions that are angiographically significant? Do you IFR or do you do physiology in the same setting, or you differ the patient to do kind of non-invasive study and then bring him back? I will start with Dr. Samir.
Okay. Thank you for the excellent and very practical question. As a matter of fact, we know from the literature that doing coronary physiology in the non-culprit vessel in the setting of STEMI, and it was extrapolated into the non-STEMI is valid. However, we have on the other side different sources of literature that acute coronary syndromes are a pan-coronary inflammation, and that the vasoactive materials are running into the coronary circulation. And thus, to be wise and take it side, if we opted for full revascularization in the same setting, including the non-culprit lesion, and this non-culprit lesion is equivocal and required coronary physiology, we go for it. But if we plan for staged in-hospital revascularization, I go for the functional assessment in the later session of the non-culprit. Same for the non-STEMI. However, non-STEMI, the decision is a bit more challenging because in more than half of them, we might not be able to define exactly where the culprit lesion is, and thus identification of the non-culprit is also as well a challenge.
Dr. Sawwah, any comments?
As Dr. Ahmed said, for STEMI patient, I think it's already done. We do the culprit lesions, and if the patient has any indication for doing total revascularization, shocked or something else, we can go for doing the whole total revascularization for the case. Otherwise, we will give him another session for the other vessels. For non-STEMI patient, it's usually challenging because you can't decide what is the culprit lesion for this case. Usually we go for total revascularization, especially when there is tight lesions. For me, for my own, I want to use a physiologic assessment for all cases, but we have additional issues, financial, and so we need to put in consideration. So we usually put DBR and other assessment physiologic for cases where we are in a gray zone. We can take a decision that is acute for this case. Otherwise, we go directly to for non-STEMI for total revascularization and STEMI for culprit lesion.
Right. How about in the setting of aortic stenosis? Would your physiology practice change, or what would you do different?
This is a challenging question indeed. Fortunately, for aortic stenosis in my center, we have the wave intensity analysis, and we started to do it in both aortic stenosis who have significant coronary lesions in angiography, as well as the hypertrophic cardiomyopathy patients. And we can definitely assure everyone that in these patients with the impaired cardiac output and low stroke volume, they have different waveforms than norms. And thus, we stick currently in the general practice, apart from the research work, to be very specific in answering this question. If these aortic stenosis patients were surgical candidates, yes, we might consider for the equivocal lesions to go for functional assessment in order to guide the surgeon if he has to do aortic guide replacement plus minus any surgical grafts needed for the coronaries. And if this aortic stenosis is indicated for TAVI or so, actually, because these are usually older, less mobile, less active people, we stick for if this is a significant lesion, functionally and angiographically, particularly in the proximal regions of the major coronary vessels. Otherwise, if even it is a moderately stenotic lesion, but distally, not causing by virtue chest pain, if we can separate the chest pain of the aortic stenosis from the coronary lesions, we opt not to complicate the TAVI session.
Have you read or practiced the utilization of physiology in the peripheral artery disease?
Unfortunately not from my side.
For me, not also.
Yeah. So next month in May, we are hosting a session for physiology in a peripheral artery disease. And we have a few experts talking about utilization of physiology in that vascular bed beyond the cardiac bed. And there's some more trend using it, especially in lesions that are not really angiographically convincing. So this, I just want to put a plug for that webinar. I don't do it myself, but I would like just to, we put that program together to see if there is a practice changing guidelines or recommendation in that vascular bed. All right, it looks like the third speaker is, unfortunately, would not be able to join. So any question from the audience? I'd like to thank the speaker, really phenomenal work, phenomenal really presentations and cases. And I'd like to applaud you to, especially during COVID and especially during the time of resources when they are restrained. And even here in the US, we are getting that the budget of the hospital are getting more short further. And we are really coming down to have a cost per case. And we are really being judged now by cost per case. So we have to be really vigilant in calling for equipment, what we need to do, starting from wires, balloons, physiology, and also imaging. But our practice wouldn't change. I think despite the financial restraints, our practice should be changing. Currently, my practice, when there is equivocal lesion, angiographic lesion, always physiology is the answer. And I always post IVUS based on the ultimate trial because of the result, patency, TVR. I think this is a long-term. It's to save money for the hospital from patient coming back for TVR or ISR. Is that any different in Egypt, Dr. Samir or Sawwah?
For me, I used TVR in stenting. There was a case we bought a stent, and geographically we saw that the stent is well opposed. Actually, we didn't have IVUS in this case. We use it in another cases, usually in left-leaning cases. So we already had the IFR wire while physiologic assessment of the lesion because it was an equivocal lesion. After putting the stent, still having a gradient. So we used an NC balloon and a higher NC balloon till we reached a significant improvement. So we are up or more than the cut values. So in this case, for sure, I couldn't prepare it before the procedure. It was one of the cases that I really liked the rule of TPR in the decision making, because it's not just for the stenting, it's also for sizing by a physiologic way, not by the mean name. Here we used the IFR as a guide, and I think it's we face cases like this in our life when we put a stent in a patient and we see that the stent is well opposed while doing another coronary angiography. After years, the patient is still complaining, but we can't find any issue in the patient. I think the main cause in these cases may be related to the physiologic affection of the patient. The stent is well deployed, but still there is a gradient beyond the stent. So TPR may play a great role in these cases, also in addition to IVs.
Perfect.
From my side, to be honest, we do not use IVS and or OCT and or functional assessment in 100% of the cases, but the threshold to use it is low whenever any challenge or any concern is there. However, intracoronary imaging is used 100% when dealing with left main, when dealing with CTOs or complex lesions, anticipating troubles. But for the everyday cases, if the angiographic outcome and picture was very reassuring and optimizing thing with the post dilations and so, we might spare these for the financial restraints.
Thank you. I think it's very, very good practical advice. At the end, I would like to thank Dr. Sawwah, Dr. Samir, Chantal for organizing, putting this digital platform, and also Ilya Malkoun, who really helped kind of inviting the speakers in the Middle East, putting this program and really kind of launching it in the Middle East. I would like to thank you for taking personal time to prepare the presentations, especially now it's Ramadan, it's fasting, it's hard. I mean, missing the coffee and all that, but I really appreciate you and your time and commitment. And it is phenomenal cases. I think it illustrated very nicely the utilization of physiology during pre and post, and how to differ, especially in the case of the CTO of the RCA that Dr. Samir showed us. And also Dr. Sawwah showed us how he differed in OptoCirc, because it wasn't significantly, so it wasn't physiologically significant with a 0.94. Please be safe, and thank you for your time.